Welcome back to Pill Talk. Today we are talking about something very important but often overlooked, that are drug-induced renal disease. Yes, some medicines that are meant to heal us can actually harm our kidneys. So in this video we will explore how this happens, which drugs are commonly responsible, and what precautions we can take. So let's get started. Drug-induced kidney disease, also called nephrotoxicity, happens when certain medicines damage the kidneys. It can show up in many ways like acid-base problems, electrolyte imbalances, or even protein and blood in the urine. So the most common sign is a drop in the kidney function, which we measure by a fall in GFR and a rise in creatinine and blood urea nitrogen levels. So what is the good news? So in many cases, the kidney damage is reversible if we stop the offending drug early enough. When drug-induced kidney disease develops, the most common problem we see is a fall in GFR, which causes creatinine and blood urea nitrogen levels to rise. So patient may feel weak, there will be loss of appetite, he would have nausea, vomiting, swelling, or even shortness of breath. So a key warning sign is reduced urine output. In some cases, certain drugs may injure the proximal tubules. It will lead towards metabolic acidosis, sugar in urine, and the loss of important electrolytes. So others may damage the distal tubules. It will cause excessive urination, high potassium levels, and problems with acid balance. So how do we confirm drug-induced kidney injury in the lab? So one key marker is serum creatinine. If creatinine rises by at least 0.5 mg per deciliter in patients with normal baseline values, or by more than 30% in those with already high levels, it strongly suggests that kidney is injured. So especially it does happen soon after starting a drug. So serum creatinine is our early red flag. Besides serum creatinine, there are neuromarkers that help detect kidney injury much earlier. For example, enzymes like N-acetyl beta-D-glucosaminidase, gamma-glutamyl transpeptidase, and glutathione transferase, along with interleukin-18, they point towards proximal tubular injury. So another marker, which is N-gal protein, it can show up in urine just within 3 hours of kidney ischemia. And kidney injury molecule, which is also known as KIM1, it is strongly linked to acute tubular necrosis. It appears in urine within about 12 hours after injury. So now this slide is really important since it connects drug classes with kidney damage patterns. So drug-induced kidney damage can happen in different ways. And number 1 is tubular epithelial cell damage. Number 2, hemodynamic injury. Number 3, obstructive nephropathy. And number 4, glomerular disease. Number 5, Tubulointerstitial disease. And number 6 is vascular injury. So one of the main ways drugs injure the kidneys is by damaging tubular epithelial cells. So the cause is usually the direct toxic or ischemic effect of the drug on the kidney tissue. This can happen in two forms. Number 1 is acute tubular necrosis, where the tubular cells die off, or osmotic nephrosis, which occurs when substances like mannitol or certain contrast agents overload the tubules and it will cause swelling. So both of these can seriously reduce kidney function if they are not recognized early. So a classical example of tubular epithelial damage is with aminoglycoside antibiotics. So these drugs damage both the proximal and distal tubules. Clinically, patient shows a gradual rise in serum creatinine, usually within 6 to 10 days of therapy. So interestingly, urine output may still look normal. This is called non-oliguric renal failure, means kidneys are still producing urine but not filtering waste effectively. So how do aminoglycosides actually damage the kidneys? The injury mainly affects the proximal tubular epithelial cells. It will lead towards the obstruction of the tubules and even back leakage of glomerular filtrate. Because these drugs carry a positive charge, they bind to negatively charged phospholipids in kidney tubule membranes. So this will allow them to accumulate inside the cells where they disrupt lysosomes. They will release harmful enzymes and they will generate reactive oxygen species, all of which cause cell death. So two key factors increase the risk: high dose and long duration of therapy. Interestingly, the uptake of aminoglycoside is a saturable process. So after one dose, only a limited amount can be reabsorbed. But with repeated exposures, toxicity builds up. So here is to summarize how aminoglycosides damage the kidneys. They accumulate inside proximal tubular cells where they get trapped in lysosomes. Over time, these lysosomes rupture. They will release reactive oxygen species and enzymes that kills the cell. So this leads to tubular obstruction and back leak of filtrate, which lowers further GFR and results in acute kidney injury. So the main risk factors are high dose and long-term therapy. So not every patient given aminoglycosides will develop kidney damage, but certain risk factors make it much more likely. So high risk comes with a large cumulative dose, prolonged therapy, or high drug levels in the blood. So danger also increases when aminoglycosides are combined with other nephrotoxic drugs like amphotericin B, cyclosporin, vancomycin, or diuretics. And finally, patient conditions matter. Dehydration, older age, liver disease, pre-existing kidney problems, malnutrition, or electrolyte deficiencies, they all raise the risk of toxicity. So both the drug factors and the patient's health status determine the outcome. How can we prevent aminoglycosides-induced kidney injury? Firstly, whenever possible, you should use alternative antibiotics like fluoroquinolones or high-generation cephalosporins. We should avoid dehydration since low fluid levels make kidneys more vulnerable. You should use the lowest effective dose and monitor drug levels. That's what we call therapeutic drug monitoring. A single once daily dose is safer than multiple divided doses. And finally, avoid aminoglycosides in patients who are elderly, immunocompromised, or already have kidney disease. Let's talk about management. So when a patient is on aminoglycosides, kidney function must be watched very closely. Serum creatinine should be checked every 2 to 4 days. If creatinine rises by 0.5 mg per deciliter or more, the drug should be stopped or the dose should be adjusted. Other nephrotoxic drugs should also be discontinued if possible. Patients should stay well hydrated and stable. So in severe cases, short-term dialysis may be needed until the kidneys recover. So careful monitoring and early interventions are key to preventing permanent damage. Another cause of tubular damage is radiographic contrast media. It often used in imaging tests like CT scans. The clinical picture can vary. Some patients remain non-oliguric with only mild enzyme leakage in urine, but in high-risk patient, contrast can cause severe oliguric kidney failure with urine output dropping below 500 ml per day, sometimes even requiring dialysis. So the injury usually appears within the first 12 to 24 hours after contrast exposure. Serum creatinine typically peaks within 2 to 5 days, and recovery usually takes 4 to 10 days if managed properly. So let's talk about pathogenesis. So why does contrast media harm the kidneys? It is mainly due to a direct tubular toxicity and renal ischemia. Renal ischemia happens when there is a low blood pressure or renal vasoconstriction, meaning the blood vessels in the kidney tighten. So this is driven by an imbalance of factors like prostaglandins, adenosine, nitric oxide, and endothelin. So dehydration makes things worse by concentrating the blood. It will increase viscosity and even causing red blood cell aggregation. The end result is reduced kidney blood flow and oxygen delivery, which amplifies tubular damage. So to sum it up, contrast nephrotoxicity is caused by two main mechanisms: direct tubular toxicity and renal ischemia. Systemic hypertension plays a big role as it reduces blood flow to the kidney. So this can be triggered by vasodilators like histamine, nitric oxide, and prostaglandins. So in addition, osmotic diuresis from contrast can cause dehydration, and changes in red blood cells increase blood viscosity. So the final result is reduced renal perfusion, ischemia, and ultimately acute kidney injury. So now risk factors and prevention. So not everyone exposed to contrast develops kidney damage, but certain groups are at high risk. So this include patients with pre-existing kidney disease, diabetes, heart failure, dehydration, myeloma, or high calcium levels. So the risk also carries with higher doses of contrast. So how can we prevent it? We can use the lowest possible dose of contrast. We could prefer non-ionic, low, or isoosmolar agents. You should avoid giving other nephrotoxic drugs at the same time like NSAIDs or aminoglycosides. You should ensure patients are well hydrated, ideally with IV saline before and after the procedure. In high-risk cases, sodium bicarbonate infusion or N-acetylcysteine may help protect the kidneys. So these steps greatly reduce the chance of contrast-induced acute kidney injury. Now management. So unfortunately, once contrast nephrotoxicity develops, there is no specific therapy to reverse it. So the best approach is careful monitoring. You should check serum creatinine, urine output, and fluid balance regularly. Supportive care is key. Keep the patient well hydrated and hemodynamically stable. In severe cases, when kidney function drops critically, dialysis may be required until recovery occurs. So prevention remains the most powerful strategy here. Now, the third one is cisplatin, a chemotherapy drug which is well known for causing kidney damage, which is having an incidence of about 6 to 13%. In fact, patients treated with cisplatin often experience a 20 to 40% decline in GFR. It makes it one of the most nephrotoxic anti-cancer agent. So carboplatin, on the other hand, is a second generation platinum drug. It is much safer for the kidneys with a lower incidence of nephrotoxicity and is often preferred in high risk patients. If we talk about the clinical presentation, so in cisplatin induced kidney injury, serum creatinine usually peaks around 10 to 12 days after therapy begins, so with recovery taking up to 3 weeks. Unlike some other drug injuries, cisplatin damage is dose related and often irreversible. It can also cause electrolyte imbalances like low calcium and potassium, but the most serious complication is severe hypomagnesemia, which may lead to seizures, muscle irritability, and even personality changes. So these symptoms can persist for a long time. It will make cisplatin nephrotoxicity particularly challenging to manage. About the pathogenesis, cisplatin injures the proximal tubular cells directly. It binds to protein and sulfhydryl groups. It interferes with enzyme activity and it will damage mitochondria. So this leads to reduced ATP production, so the cells lose their energy supply. So as a result, oxidative stress builds up inside the cell. Enzyme function fails and the cells undergo death. So this energy crisis inside the kidney is the main reason why cisplatin nephrotoxicity can be so severe and long lasting. And now risk factors. Certain patients are more vulnerable to cisplatin-induced kidney injury, so the risk is higher in those who are elder, dehydrated, or have had renal irradiation. It also increases when cisplatin is combined with other nephrotoxic drugs like aminoglycosides, antibiotics, and finally alcohol abuse can worsen the toxicity. So recognizing these risk factors help us identify patients who need closer monitoring and preventive measures. And now prevention. Preventing cisplatin nephrotoxicity starts with dose reductions and giving the drug less frequently, often in combination with other chemotherapeutics. We should also avoid using cisplatin together with other nephrotoxic drugs. The most effective protection is a vigorous hydration with isotonic saline, aiming for at least 100 ml of urine output per hour. Hydration is continued during and after cisplatin infusion, usually at a rate of 150 to 250 ml per hour. So in addition, diuretics like furosemide or mannitol can be given before or with cisplatin to help maintain high urine flow and reduce kidney damage. One special drug used to protect the kidneys from cisplatin toxicity is amifostine. It's an organic thiophosphate that converts into an active metabolite inside the body. So this metabolite binds cisplatin in normal cell. It will reduce nephrotoxicity, neurotoxicity, ototoxicity, and even bone marrow suppression. Amifostine pretreatment is especially useful in elderly patients, those with chronic kidney disease, or patients already receiving other nephrotoxic drugs. Other protective methods include hypertonic saline, which lowers cisplatin uptake in tubules, and N-acetylcysteine, which reduces oxidative stress by donating sulfhydryl groups. So together, these strategies can significantly lower the risk of permanent kidney injury. Recently, new protective methods against cisplatin toxicity have been explored. Studies show that melatonin and cisplatin-loaded polymeric micelles can maintain anti-cancer activity while reducing kidney damage. Another strategy is intraperitoneal administration, which lowers kidney exposure, especially when combined with systemic sodium thiosulfate. So this is particularly useful for patients with peritoneal tumors. So these novel approaches may create the way for safer chemotherapy in the future. And now management. Management of cisplatin-induced kidney injury focuses on monitoring and supportive care. The kidney damage is often partially reversible with time. Renal function tests like creatinine and BUN must be checked daily. Electrolytes, especially magnesium, potassium, and calcium, should also be monitored closely and corrected whenever it is necessary. However, with cumulative doses, kidney disease may become irreversible, and in some cases, patient may require chronic dialysis support. Number 4. Now let's look at amphotericin B, which is a powerful antifungal drug which is well known for its nephrotoxicity. Kidney toxicity usually appears after a cumulative dose of about 2 to 3 grams. So the clinical picture includes wasting of electrolytes such as potassium, sodium, and magnesium, along with an impaired ability to concentrate urine. It can also cause distal renal tubular acidosis due to hydrogen ion leakage from the tubules. In addition, there is a decrease in renal blood flow and GFR. It will also lead towards a rise in serum creatinine and BUN levels. So because of this, patients often require potassium and magnesium replacement, and they also require regular monitoring of renal function tests. And the pathogenesis. The kidney damage caused by amphotericin B is due to two main mechanisms. Firstly, there is direct tubular epithelial cell toxicity, which increases membrane permeability and it will lead toward necrosis. Second is arterial vasoconstriction, which reduces renal blood flow and causes ischemic injury. Together, these effects increases cellular energy demand. It will reduce oxygen delivery and ultimately results in tubular cell necrosis and impaired kidney function. So here to summarize the mechanism, amphotericin B increases oxygen demand because the damaged and leaky tubular cells have to work harder. At the same time, it decreases oxygen supply due to renal vasoconstriction and ischemia. So this imbalance creates more demand but less supply, ultimately causes renal medullary tubular epithelial cell necrosis, which will lead towards acute kidney injury. Now here are the amphotericin B risk factors. Certain patients are at high risk of kidney injury from amphotericin B. So these include those with chronic kidney disease, patients receiving higher daily doses, and those with volume depletion. The risk also increases with concomitant use of diuretics or other nephrotoxic drugs, especially cyclosporin. Finally, rapid infusion of amphotericin B significantly worsens the nephrotoxicity, so the infusion rate is very important in minimizing the damage. Now, prevention and management. So, to reduce the risk of amphotericin B induced kidney injury, several strategies can be used. Firstly, switch towards liposomal amphotericin B formulation, which is much safer. Secondly, the cumulative dose should be limited and the use of other nephrotoxic drugs like cyclosporin should be avoided. Most importantly, hydration with 1 liter of intravenous saline daily during therapy significantly lowers the risk. For management, if nephrotoxicity develops, the drug should be discontinued or substituted with an alternative. Additionally, renal function tests, electrolytes, and serum levels of magnesium, potassium, and calcium should be closely monitored and corrected when needed. Now let's talk about osmotic nephrosis, which is a condition characterized by vacuolization, swelling, and eventually necrosis of proximal tubular epithelial cells, leading towards a decline in kidney function. It often occurs due to the hypertonic and osmotically active nature of certain drugs, commonly referred to as volume expanders. Example of drug responsible include mannitol, low molecular weight dextran, radiographic contrast agents, sucrose, or propylene glycol, such as drug vehicles, intravenous immunoglobulin solutions containing sucrose, and hydroethyl starch. Fortunately, this toxicity can be prevented by diluting the solution and reducing the rate of infusion. Now the first one, mannitol. Though rarely can cause kidney injury characterized by proximal tubular cell vacuolization seen on biopsy. The mechanism include direct renal vasoconstriction or an osmotic diuresis, which increases solute delivery to the macula densa. It will ultimately lead toward afferent arteriolar vasoconstriction and reduced renal blood flow. Risk factors include excessive doses, pre-existing kidney disease, and concomitant use of diuretics or cyclosporin. For prevention, toxicity can be avoided by limiting the dose, avoiding dehydration, and monitoring concurrent therapy. Importantly, patients usually recover normal kidney function after drug withdrawal or hemodialysis, so when mannitol concentration returns to safe levels. Now let's move on towards second type, which is hemodynamically mediated kidney injury. So it occurs when there is a decrease in intraglomerular pressure. The mechanism typically involves reduced renal blood flow, vasoconstriction of the afferent arteriole, and vasodilation of the efferent arteriole. With ACE inhibitors and ARBs, this manifests as an acute reduction in GFR, a moderate rise in serum creatinine around 0.1 to 0.3 mg per deciliter. In some cases, creatinine can rise up to 30% within 2 to 5 days of starting therapy. So if serum creatinine increases by 0.5 mg per deciliter or more within 1 to 2 weeks, so this may require discontinuation of the offending drug. So fortunately, this rise in creatinine usually stabilizes within 2 to 3 weeks and is reversible once the medication is stopped. So the risk factors are those who are highly dependent on angiotensin II to maintain their blood pressure and renal perfusion. These include individuals with renal artery stenosis where kidney perfusion is already compromised, congestive heart failure where cardiac output is already low, volume depletion such as form of excessive diuresis or gastrointestinal fluid loss, hepatic cirrhosis with ascites where effective circulating volume is already reduced, and nephrotic syndrome where there is a significant protein loss and fluid imbalance. So in these groups, ACE inhibitors and ARBs can easily tip the balance, leading to acute kidney injury. Now the pathogenesis. Under normal conditions, the kidney tries to preserve GFR by dilating the afferent arteriole and constricting the efferent arteriole when renal blood flow is reduced. So, this is largely controlled by angiotensin II, which increases intraglomerular pressure by constricting the efferent arteriole. However, when we start ACE inhibitors or ARBs, the production or action of angiotensin II is blocked. As a result, the efferent arteriole can no longer constrict properly. So this leads to a fall in glomerular hydrostatic pressure, reducing ultrafiltration and ultimately lowering the GFR. In short, ACE inhibitors and ARBs protect the kidney long term, but in certain patients they can cause an acute fall in kidney function due to this mechanism. Now, prevention. To prevent kidney injury related to ACE inhibitors or ARBs, the first step is recognizing patients who are at risk, such as those with pre-existing kidney disease, volume depletion, heart failure, or liver disease. Therapy should be started with a very low dose of a short-acting ACE inhibitors like captopril, and then the dose can be slowly titrated upward. Once tolerance is established, patients can be shifted to a longer-acting agent such as lisinopril. It's also very important to monitor renal function tests and potassium levels regularly for hospitalized patients. Monitoring should be daily, and for outpatients every 2 to 3 days. Finally, avoid using other drugs that affect renal hemodynamics such as NSAIDs or diuretics, and make sure the patient does not become dehydrated. And management of hemodynamically mediated kidney injury begins with discontinuation of the offending drug. If the patient develops severe hyperkalemia, treatment is required. One of the common approach is using sodium polystyrene sulfonate suspension, which helps remove excess potassium from the body. Second one are NSAIDs or selective COX-2 inhibitors. They can also cause hemodynamically mediated kidney injury. The clinical presentation usually occurs within just a few days of starting therapy, especially with short-acting drugs like ibuprofen. Symptoms include reduced urine output, weight gain, and swelling or edema. Laboratory tests often show low urine volume and sodium concentration, while blood urea nitrogen, serum creatinine, and potassium are elevated. In addition, the urine may show granular cast. And now, pathogenesis. NSAIDs cause kidney injury by inhibiting COX enzymes. This reduces the production of vasodilatory prostaglandins from arachidonic acid. Under normal condition, prostaglandins don't play a big role in renal blood flow, but in states of reduced blood flow, such as dehydration or ischemia, they become critical to prevent kidney hypoxia by opposing vasoconstrictors like angiotensin II, norepinephrine, endothelin, and vasopressin. So when NSAIDs block this protective prostaglandin pathway, the balance shift in favor of vasoconstrictors. It will lead towards reduced renal blood flow, ischemia, and loss of glomerular filtration. So certain patients are at much higher risk of kidney injury when exposed to drugs that affect renal blood flow. These include individuals with chronic kidney disease, liver disease with ascites, and those with heart failure. Other risk factors are intravascular volume depletion, such as from dehydration or diuretics, and systemic conditions like lupus. Elderly patients, as well as those with atherosclerotic cardiovascular disease or receiving concurrent diuretic therapy, are also especially vulnerable. And the prevention of drug-induced hemodynamic kidney injury begins with recognizing high-risk patients. Safer alternatives should be used where possible, such as analgesics with less prostaglandin inhibition like acetaminophen or non-acetylated salicylates. Non-narcotic analgesics like tramadol may be considered, although they lack anti-inflammatory effects. If NSAID therapy is unavoidable, clinicians should use the lowest effective dose for the shortest duration and monitor renal function tests closely. Finally, the use of concurrent hypotensive agents such as ACE inhibitors should be avoided to minimize further impact on renal hemodynamics. And the management begins with discontinuation of the offending therapy and providing supportive care. Fortunately, this type of kidney injury is really severe. In most cases, recovery is fairly rapid once the drug is withdrawn. However, if the injury progresses and becomes severe, steroid therapy may be beneficial to control inflammation and improves recovery. Number 3, another important cause of hemodynamically mediated kidney injury is cyclosporin and tacrolimus. That are two immunosuppressive drugs widely used in transplant patients. The incidence of nephrotoxicity with these agents is quite high, and it has been observed to occur frequently in transplant recipients, especially within the first 6 months of cyclosporin therapy. This highlights the importance of close monitoring in the early post-transplant period to prevent kidney injury. And now the clinical presentation. Acute kidney injury may caused by cyclosporin and tacrolimus can appear within just a few days of starting therapy. Clinically, patient shows a rise in serum creatinine concentration, a fall in creatinine clearance, hypertension, hyperkalemia, sodium retention, and hypomagnesemia are also commonly seen. Interestingly, there is no urine sediment abnormality, which makes it different from any other causes of AKI. On biopsy, changes may include thickening of arterioles, focal glomerular sclerosis, vacuolization, and atrophy of proximal tubular epithelial cells and interstitial fibrosis. The high risk factors include older age, especially those over 65 years, those receiving a higher initial dose of cyclosporin, patients with renal graft rejection, conditions such as hypotension or infection, and importantly, concomitant use of other nephrotoxic drugs. These may include aminoglycosides, amphotericin B, acyclovir, NSAIDs, radiocontrast agents, or drugs that inhibit cyclosporin metabolism in the liver. All these factors can increase the likelihood of nephrotoxicity. And now the pathogenesis. The kidney injury caused by cyclosporin and tacrolimus is mainly due to hemodynamic and structural changes. Initially, there is a dose-related hemodynamic mechanism. This means that in the early months of therapy, kidney function may decline but can improve quickly after dose reduction. So the drugs cause reversible vasoconstriction of glomerular afferent arterioles, reducing renal blood flow. So this is thought to be due to increased activity of mediators like thromboxane A2, endothelin, and the renin-angiotensin systems, along with the decreased nitric oxide activity. But with long-term use, structural damage occurs. So this includes renal arteriolar hyalinization, chronic ischemia, and increased extracellular matrix synthesis. These changes contribute to progressive chronic kidney disease in patients on cyclosporin therapy. Prevention of cyclosporin or tacrolimus-induced kidney damage requires close pharmacokinetic and pharmacodynamic monitoring. One important strategy is the use of calcium channel blockers. So these drugs can counteract the vasoconstrictor effect of cyclosporin by dilating the glomerular afferent arterioles, which help maintain renal blood flow and filtration. Another preventive measure is to reduce the doses of cyclosporin or tacrolimus, especially when they are used in combination with other non-nephrotoxic immunosuppressants. This minimizes the risk of toxicity while still maintaining therapeutic effects. Management depends on whether the patient develops acute kidney injury or chronic kidney disease. Acute kidney injury or AKI usually improves with dose reduction, treatment of any contributing illness, or by stopping interacting drugs. On the other hand, chronic kidney disease, or we can say CKD, is usually irreversible. However, a progressive toxicity can be slowed down by reducing the dose or discontinuing cyclosporin or tacrolimus while maintaining other immunosuppressants. Finally, serum creatinine and BUN levels should be closely monitored, ideally on a daily basis, to track kidney function and detect worsening early. Let's move towards the third category of drug-induced renal disease, that is obstructive nephropathy. This condition results from a mechanical obstruction of urine flow after glomerular filtration. There are two main types: a primary cause, which includes intratubular or post-renal obstruction, and a secondary cause, which is most often due to nephrolithiasis or prostatic hypertrophy. Focusing on intratubular obstruction, this usually happens because of precipitation of drug metabolites or tissue breakdown products inside the tubules. A common example is tumor lysis syndrome, which is caused by chemotherapy, where rapid tumor tissue degradation leads to intratubular blockage. This condition can cause acute oliguric or even anuric kidney injury, which is often associated with acute uric acid nephropathy. So diagnosis of obstructive nephropathy due to uric acid precipitation can be made when the uric acid to creatinine ratio is greater than 1. For treatment and prevention, there are three key strategies. Prevention or pre-treatment hydration with normal saline, aiming to maintain a urine output of more than 2.5 liters per day. Allopurinol therapy, usually 300 to 600 milligrams daily, started 2 to 3 days before chemotherapy to reduce uric acid formation. Urinary alkalinization to a pH of 7, which helps dissolve uric acid and prevents its crystallization in the tubules. Another important cause of obstructive nephropathy is the intracellular precipitation of drugs or their metabolites. So this typically happens when the urine pH drops to around 4.5. It will make the environment very acidic. So at this pH, certain solutes can precipitate and block the tubular lumen, especially in patients with concentrated urine or volume depletion. Drugs commonly involved include acyclovir, sulfadiazine, methotrexate, ascorbic acid, which is in high dose, dextran, triamterene, foscarnet, and endenavir. Interestingly, this complication can be prevented in up to 75% of patients simply by maintaining adequate hydration, about 2 to 3 liters of fluid per day. Another form of obstructive nephropathy is caused by drug-induced rhabdomyolysis. In this condition, muscle breakdown releases myoglobin, which can precipitate inside the renal tubules. This leads to tubular obstruction and, if severe, results in acute kidney injury. The main cause is direct muscle toxicity from HMG coenzyme A reductase inhibitors, commonly known as statins, such as lovastatin and simvastatin. The risk of rhabdomyolysis increases significantly when statins are combined with drugs like gemfibrozil, niacin, or CYP3A4 inhibitors such as erythromycin and itraconazole. Another cause, or we can say type, of obstructive nephropathy is nephrolithiasis, or the formation of kidney stones. In this condition, the glomerular filtration rate usually remains normal, but abnormal crystal precipitation occurs within the renal collecting system. The symptoms often include pain, blood in the urine, a recurrent infection, or in severe cases, urinary tract obstruction leading towards the kidney injury. Several drugs are known to cause nephrolithiasis, including triamterene, sulfadiazine, endenavir, nelfinavir, foscarnet, ciprofloxacin, amoxicillin, and nitrofurantoin. Additionally, products containing ephedrine, norepinephrine, and pseudoephedrine may also contribute. Now let's move on towards glomerular disease, which often arises due to immune-mediated mechanisms. Patients typically present with proteinuria, which can occur with or without a decline in glomerular filtration rate. In some cases, the injury may be minimal but still lead to nephrotic range proteinuria greater than 3.5 grams per day. This condition is often accompanied by interstitial nephritis, commonly linked to drugs such as NSAIDs, ampicillin, rifampin, phenytoin, and lithium. The exact pathogenesis remains unknown, but the immune response is believed to play a central role. In some patients, nephrotic range proteinuria develops as a result of NSAID therapy, often linked with T lymphocyte mediated injury. Another important pattern is focal segmental glomerular sclerosis, which is marked by patchy areas of glomerular scarring combined with interstitial inflammation and fibrosis. FSGS is the most common renal lesion in AIDS patients and can also be seen in cases of HIV infection or heroin abuse. When glomerular sclerosis is caused by HIV, it can be recognized by the presence of tubulo-reticular structures in the endothelial cells seen under electron microscopy. Unfortunately, this form often has a faster progression and poorer prognosis. Certain drugs are also linked to glomerular injury. For example, the bisphosphonate pamidronate, often used to treat cancer-related hypercalcemia, has been associated with a severe form called collapsing FSGS. Another condition is membranous nephropathy, which is mediated by immune complexes. It has been classically associated with gold therapy, penicillamine, and long-term NSAID use. The underlying pathogenesis may involve damage to the proximal tubular epithelium, release of antigens, formation of antibodies, and finally, glomerular immune complex deposition. So, the next one is Tubulointerstitial Disease, which involves both the renal tubules and the surrounding interstitial tissue. They can present in two major forms. Number one is acute and number two is chronic. Acute one is usually reversible and it is characterized by interstitial inflammatory cell infiltrates. Patients often experience a rapid loss of renal function and there may be systemic symptoms such as fever, rash, or malaise. Chronic one is usually irreversible. It leads to interstitial fibrosis and permanent scarring. Clinical symptoms are often minimal and even absent, making it harder to detect early. Tubulointerstitial disease can be further classified into four main types: acute allergic interstitial nephritis, chronic interstitial nephritis, nephrocalcinosis, and number 4, papillary necrosis. Let's start with acute allergic interstitial nephritis, which is an important cause of drug-induced kidney injury. It is responsible for up to 3% of all cases of acute kidney injury. Acute allergic interstitial nephritis typically appears about 2 weeks after exposure to a drug, although it can develop much earlier if the patient has been previously sensitized. This highlights how the immune system plays a central role in triggering the condition. Now the first one, methicillin-induced allergic interstitial nephritis. which is considered the prototype of AIN. Today, however, we know that AIN can occur with almost all beta-lactam antibiotics. So the symptoms typically appear within 14 days of starting therapy. These include fever, maculopapular rash, eosinophilia, pyuria, hematuria, low-level proteinuria, and oliguria. Other important findings are eosinophiliuria, which are present in 60% of cases, which serves as a key marker along with leukocytosis. In addition, tubular dysfunction may occur, leading to acidosis, hyperkalemia, salt wasting, and concentrating defects. Now let's look at NSAID-induced tubulointerstitial disease. This type has a different clinical presentation compared to other drug-induced nephritis. It is usually seen in patients older than 50 years of age, and the onset is delayed, often appearing after about 6 months of therapy. Patients typically show a much lower incidence of fever, rash, and eosinophilia, with external symptoms reported in only about 10% of cases. Most importantly, a significant number of patients develops concomitant nephrotic syndrome with proteinuria greater than 3.5 grams per day, seen in over 70% of cases. A classical example is phenoprofen allergic interstitial nephritis, which serves as the prototype, accounting for nearly 50% of such cases. Prompt diagnosis is essential to prevent irreversible kidney damage, and while biopsy is the gold standard for diagnosis, it is not always preferable in acute presentations. Now let's discuss the pathogenesis. So AIN is characterized by a diffuse or focal infiltration of inflammatory cells, including lymphocytes, plasma cell, eosinophils, and sometimes neutrophils. In many cases, we can also see granulomas in even tubular epithelial cell necrosis. So the underlying mechanism is often an allergic hypersensitivity reaction. In some cases, a humoral antibody-mediated process is involved, where antibodies react to a drug hapten complex bound to the tubular basement membrane, leading to low complement levels and deposition of immunoglobulins. So more commonly, however, AIN is driven by a self-mediated immune mechanism. This is suggested by the predominance of T lymphocyte infiltration, often with an increased helper to suppressor cell ratio. In particular, with NSAID-induced AIN, T cells play a central role, possibly triggered by altered prostaglandin synthesis. Now let's move on to the risk factors, prevention, and management of drug-induced tubulointerstitial disease. Interestingly, there are no well-defined risk factors, but it is usually an idiosyncratic hypersensitivity reaction. Patients who already have a history of other drug allergies may be at increased risk and should be monitored closely. In terms of prevention, there are no specific measures. The key is to monitor patients carefully, because early recognition and discontinuation of the offending drug often leads to complete recovery. For management, corticosteroid therapy can be considered in patients whose renal function doesn't improve after drug withdrawal. The recommended regime is prednisone, starting at 1 mg per kg per day for 1 week, followed by a taper over 3 weeks before discontinuation. During treatment, renal function indices such as serum creatinine and BUN, as well as signs and symptoms of AIN, must be monitored closely to assess improvement. Let's discuss chronic interstitial nephritis. Lithium, which is a drug commonly used for mood stabilization, has significant renal side effects. The most common is an impaired ability to concentrate urine, also known as nephrogenic diabetes insipidus, which has been reported in up to 87% of patients. In some cases, patients may also develop distal renal tubular acidosis, occurring in nearly 50% of patients. Less commonly, lithium can cause acute tubular necrosis or progress to chronic tubulointerstitial nephritis. It is important to note that these complications are dose and duration dependent, meaning that long-term or high-dose lithium therapy carries a much greater risk. When it comes to clinical presentation, lithium-induced tubulointerstitial disease often appear as nephrogenic diabetes insipidus. Patient may experience polydipsia or excessive thirst, seen in about 40% of cases, and polyuria and excessive urination, occurring in around 20% of cases. In cases of acute lithium toxicity, there may be acute tubular necrosis. Urine analysis usually shows moderate proteinuria with only a few red and white blood cells and granular gas. Other features include rising blood urea nitrogen and creatinine level. In some patients, the development of hypertension as well. The pathogenesis of lithium-induced tubulointerstitial disease is mainly due to the impaired ability of the kidney to concentrate urine. This happened because of a dose-related decrease in the collecting duct's response to antidiuretic hormone. So this impairment results from detective formation of cyclic AMP in response to ADH. Lithium-induced acute kidney injury often occurs during episodes of acute lithium intoxication. Other contributing mechanisms include dehydration from nephrogenic diabetes insipidus and direct toxicity to proximal and distal tubular cells. For diagnosis, chronic tubulointerstitial nephritis linked to lithium is usually confirmed by biopsy findings. These typically show interstitial fibrosis, tubular atrophy, and glomerular sclerosis. Now let's look at the risk factors. Patients on lithium therapy are at high risk of kidney injury if they have elevated lithium concentration, dehydration, or are receiving concomitant therapy with neuroleptic agents. Moving on to prevention. So the key is to maintain lithium concentration as low as possible while still being therapeutically effective. Patient must also avoid dehydration and renal function should be monitored regularly. If renal function continues to decline, lithium therapy should be discontinued to prevent irreversible kidney damage. Now let's move on to the management. For patients who develop polyuria and polydipsia, the first step is discontinuation of lithium therapy whenever possible. If lithium must be continued, amiloride 10 mg daily can be prescribed. Amiloride helps by reducing lithium entry into the renal tubular cells, thereby decreasing its nephrotoxic effects. If polyuria does not improve within 7 to 10 days, the dose of amiloride should be increased to 20 mg daily. Acute kidney injury caused by lithium is usually reversible with supportive care, including dialysis if needed. In contrast, progressive chronic interstitial nephritis requires more long-term management. The main steps include discontinuation of lithium therapy whenever possible, ensuring proper hydration, and avoiding other nephrotoxic agents. Additionally, lithium serum concentration and renal function markers such as urine output, blood urea nitrogen, and serum creatinine should be closely monitored to track recovery and prevent further toxicity. Secondly, cyclosporin. Chronic tubulointerstitial disease due to cyclosporin is usually reported after 6 to 12 months of therapy. Unfortunately, this damage can be irreversible. The clinical course shows a gradual rise in serum creatinine and a decline in creatinine clearance. Histologically, it is marked by arteriolar hyalinosis, glomerular sclerosis, and a striped pattern of tubulointerstitial fibrosis. Importantly, this condition is often dose-dependent, but it can also occur even at low doses, making close monitoring essential. The underlying pathogenesis of cyclosporin-induced tubulointerstitial disease involves sustained injury to renal arteriolar endothelial cells, which eventually leads to chronic renal ischemia. This injury is mediated by multiple mechanisms, including increased release of endothelin-1, decreased production of nitric oxide, and increased expression of transforming growth factor beta. Together, these changes promote vasoconstriction, fibrosis, and long-term structural damage in the kidney. Aristolochic acid, commonly associated with certain Chinese herbal weight loss regimes, has been strongly linked to the development of nephropathy. Incidence studies suggest that around 3 to 5% of patients exposed to these regimes develop kidney disease, with many progressing to end-stage renal disease. Clinically, patients present with mild to moderate hypertension, proteinuria, and glycosuria, along with elevated serum creatinine levels. Over time, anemia and shrunken kidneys become evident. Pathological findings typically shows interstitial fibrosis, tubular atrophy, and destruction of renal tubules throughout the cortex. Importantly, the glomeruli are not affected, which distinguishes this condition from many other nephropathies. One of the most alarming features of aristolochic acid nephropathy is very fast progression. Patients often develop end-stage renal disease requiring dialysis or kidney transplantation within just 6 to 24 months of exposure. Even more concerning is the strong link between aristolochic acid and urothelial cancers. Studies, particularly in Belgian patients, showed a 40% prevalence of transitional cell carcinoma in those who underwent renal transplantation after developing nephropathy. This highlights the dual threat of aristolochic acid exposure, rapid progression to kidney failure, and a markedly increased risk of malignancy. The exact mechanism of how aristolochic acid causes kidney injury and cancer is still not fully characterized. However, research shows that it can directly damage DNA. Its major components are metabolized into mutagenic compounds, aristolectin 1 and 2, which form DNA adducts in human, driving both nephropathy and urothelial carcinoma. In terms of prevention, the most important step is simply avoiding exposure. Several countries, including the UK, Canada, Australia, and Germany, have completely banned Aristolochia containing herbs due to their strong link with kidney failure and cancer. Next one is nephrocalcinosis. So it occurs when calcium phosphate precipitates and deposits within the tubulointerstitial tissue, leading to marked tubular calcification. The main risk factor is hypercalcemia, okay? So which may result from conditions like hyperparathyroidism, increased bone turnover, malignancy associated like hypercalcemia, or excessive intake of calcium and vitamin D. Interestingly, nephrocalcinosis has also been reported in patients without hypercalcemia. In such cases, the culprit is often oral sodium phosphate solution, which is also known as OSPS, which is commonly used for bowel cleansing and has been identified as a causative agent. Acute phosphate nephropathy, also known as OSPS-induced nephrocalcinosis, occurs due to increased phosphate intake rather than hypercalcemia. Its exact incidence is rare and not well defined, but it has been linked to oral sodium phosphate solution, which is used for bowel cleansing. Importantly, acute kidney injury may develop several days to even months after exposure to OSPS, making it a delayed but serious complication. Patients with OSPS-induced nephrocalcinosis often present with elevated serum creatinine, low-grade proteinuria, normal calcium levels, and a bland urinary sediment, meaning few abnormal findings under the microscope. The hallmark feature is the extensive deposition of calcium phosphate in the distal tubules and collecting ducts without any glomerular or vascular injury. Certain factors increases the risk of developing OSPS-induced nephrocalcinosis. These include bowel conditions with prolonged interstitial transit, use of high sodium phosphate dosage, volume depletion, diuretic therapy, concurrent use of NSAIDs, ACE inhibitors or ARBs, advanced age, and pre-existing chronic kidney disease. Patients with these risk factors should be carefully monitored while using oral sodium phosphate solution. And the next one is papillary necrosis, which is a form of chronic tubular interstitial nephritis characterized by necrosis of the renal papilla. The most common cause is prolonged use of analgesics. Historically, phenacetin-containing combination analgesics were a major culprit. Today, aspirin, acetaminophen, and NSAIDs, whether taken alone or in combination, are strongly associated with the development of analgesic nephropathy. Epidemiologically, analgesic nephropathy is significant. It has been reported as a primary cause of end-stage renal disease in up to 9% of dialysis patients. Analgesic nephropathy usually presents after at least 1 year of chronic analgesic use. It is often difficult to diagnose and frequently remain underdiagnosed as a cause of end-stage renal disease. For diagnosis, the key parameter is a history of chronic habitual analgesic ingestion, classically defined as daily use for at least 5 years. Imaging techniques such as intravenous pyelography, renal ultrasound, or CT scans may reveal features like decreased renal mass and a bumpy or nodular renal surface, which are characteristics of this condition. In chronic tubular interstitial disease, imaging usually reveals only chronic pyelonephritis with small kidneys, a thin renal cortex, and a blunted calycis. Patients frequently develop hypertension and may also show signs of atherosclerotic cardiovascular disease. The early renal manifestations include impaired ability to maximally concentrate urine, microscopic hematuria, and low levels of proteinuria. Additionally, urinary tract infections are common in these patients. A renal biopsy typically reveals non-specific chronic interstitial inflammation and scarring, confirming the diagnosis. The exact mechanism of analgesic nephropathy still remains somewhat unclear. What we do know is that the damage typically starts at the papillary tip of the kidney. Here, toxic metabolites accumulate, blood flow decrease, and cellular energy production becomes impaired. A key factor is the metabolism of phenacetin into acetaminophen. This acetaminophen is then further oxidized into toxic free radicals. These free radicals concentrate in the renal papilla, causing a local cellular injury. So this toxic effect is believed to act in a way very similar to acetaminophen-induced hepatotoxicity. But here the damage is targeted at the kidney instead of the liver. Normally, the body has a natural protector called glutathione, which helps prevent toxicity. But salicylates can deplete glutathione in the kidney, making it easier for drugs like phenacetin and acetaminophen they can cause damage. Okay, so now let's talk about the risk factors. Cumulative use of combination analgesics like phenacetin, acetaminophen, aspirin, or NSAID significantly raises the risk. Caffeine, often included in these drug combination, may increase the risk too, but its exact role is not very clear. Even chronic
therapeutic doses of NSAIDs alone can cause analgesic nephropathy. But interestingly, aspirin or salicylates alone usually don't. And finally, high doses of acetaminophen taken alone also increases the risk of developing kidney failure or ESRD. Finally, let's talk about prevention. First, restricting the sale of phenacetin and combination analgesic has proven effective in reducing cases. It is also important to decrease the total dose whenever possible. Patients should avoid the combined use of 2 or more analgesic, as this significantly increases the risk of kidney damage, and most importantly, maintaining good hydration is essential to protect the kidneys and prevent renal ischemia. When it comes to management, the first and most important step is the cessation of analgesic consumption. Renal function must be closely monitored through parameters such as urine output, blood urea nitrogen, and serum creatinine, ideally every few months. In addition, patients should be regularly screened for the risk of transitional cell carcinoma of the renal pelvis, calyces, ureters, or bladders, which is a complication that may appear even after the diagnosis of analgesic nephropathy. Now let's move on to renal vasculitis, thrombosis, and cholesterol emboli. Starting with vasculitis, this refers to inflammation of blood vessels that can affect the kidneys. Several drugs are responsible for drug-induced vasculitis, like propylthiouracil can cause cutaneous renal and pulmonary vasculitis. Allopurinol is linked with cutaneous renal and hepatic vasculitis. Hydralazine and isotretinoin, and finally minocycline, which is an antibiotic, has been associated with systemic polyarteritis nodosa, which is a vasculitis involving small and medium-sized renal arteries. Let's now look at the symptoms of renal vasculitis. Patients often present with hematuria, proteinuria, reduced renal function, and hypertension. Moving on to the pathophysiology, certain drugs including hydralazine, propylthiouracil, allopurinol, and penicillamine have been linked to the development of anti-neutrophil cytoplasmic antibody-positive vasculitis. Patients exposed to these drugs may develop high titers of anti-myeloperoxidase antibodies, which play a role in vascular inflammation and damage. Now let's discuss the treatment of drug-induced renal vasculitis. The first and most important step is withdrawing the offending drug. In many cases, this alone leads to gradual improvement. For patients with more severe disease, a tapering course of prednisone can be prescribed to control inflammation. With improper management, symptoms usually disappears within weeks to months, and kidney function may stabilize. Next, let's move towards drug-induced renal thrombosis. Several drugs are known to increase the risk of renal thrombosis. Among the most important is mitomycin C, which is strongly associated with thrombotic microangiopathy. Other drugs also include oral contraceptive agents, cyclosporin, tacrolimus, muromonab, CD3, and various antineoplastic agents. Additional culprits are interferon, ticlopidine, clopidogrel, tamoxifen, vinca alkaloids, bleomycin, gemcitabine, and quinine. These agents can impair the renal vasculature, leading to clot formation and subsequent kidney damage. As we already discussed, mitomycin is the most common drug responsible for thrombosis, and importantly, its toxicity is dose-related. Patients receiving doses lower than 30 milligrams per square meter are rarely affected. The clinical manifestations include microangiopathic hemolytic anemia and thrombocytopenia, systemic endothelial damage, severe and sometimes irreversible kidney injury, thrombotic microangiopathy, endothelial proliferation, and finally, thrombus formation in both the renal and central nervous system vasculature. The management of drug-induced thrombosis is complex and often requires multiple approaches. Treatment options are corticosteroids to reduce inflammation, antiplatelet agents to prevent further clot formation, vincristine in severe refractory cases, plasma exchange or plasmapheresis to remove circulating toxins or antibodies, and high-dose intravenous immunoglobulin G, which modulates the immune response. So these therapies are aimed at controlling thrombosis, preserving kidney function, and reducing systemic complications. If we move to cholesterol emboli, these drugs are responsible mainly are anticoagulants and thrombolytics, particularly warfarin. In terms of pathogenesis, these drugs can mobilize cholesterol particles from atherosclerotic plaques in the aorta, which then travel to small arteries and arterioles, including those in the kidneys. By removing or preventing thrombus formation over ulcerated plaques, these agents inadvertently trigger embolization. Symptoms include an inflammatory obliterative vascular response that leads to renal ischemia. Clinically, one striking feature is the purple discoloration of the toes and molted skin over the legs, often called blue toe syndrome. That brings us to the end of our discussion on drug-induced renal diseases. Thank you for watching. If you found this video helpful, don't forget to like, share, and subscribe to Pill Talk for more insights into medicines and their effects on the human body. Stay healthy and see you in the next video.